Hi, thank you, Cochlear, for allowing me to come and talk to this group today about the complexities associated with candidacy. Now, we're a group of audiologists and surgeons who think through this every single day. And so it might not seem as complex to us because it's a natural process that we use every single day when we're seeing our patients. But that's not the case for everybody in the hearing loss world. So I decided to kind of look at this. We have a lot of patients that are candidates for cochlear implants, but they're not necessarily coming into our clinic or your clinic. And why is that? So I pulled several of the hearing aid centers that are located within Iowa and asked them, the audiologist, do you know the new candidacy guidelines? Most of them said, not really, I'm kind of confused. And that's okay, because you know what? I don't know about the newest hearing aid that the audiologist is fitting on their patients, because I don't live that world every single day. And so it seems necessary that we come up with a way to make candidacy more streamlined, which, you know, inevitably might help our clinics, but also make it easier for referrals. We know that candidacy has evolved. We're implanting more patients with residual hearing. These patients, we know, do better if they come to us with a shorter duration of deafness, and we hope they come to us sooner than later, so they may be younger at the age of implantation. It seems kind of crazy, but most people wait 10, if not 20 years before they decide to move forward with a cochlear implant when they're already a cochlear implant candidate. Why? Seems so simple to us. Again, we live it every single day. Cochlear implants, they seem non-invasive from a surgical standpoint. We know the benefits that our patients observe, both from a quality of life and the way they interact in their real worlds. But again, we go back to access and awareness for professionals that are outside of our clinic. Most of the audiologists that I talked to, they said, you know, I'm confused and I don't want to refer someone to your clinic who really isn't a candidate and then makes me look silly, like I'm not really up to date. And that's not the case at all. You know, we want, and I've told them, we want them to come in. If you think that that patient might benefit from a cochlear implant, send them in. We'll work through those complexities for you. If they're not a candidate, we'll send them back to your clinic. And that's absolutely okay, because now that patient has a shoe in the door. They're going to be followed. We're going to keep up with them, maybe bring them back a year later, see if things have changed. But getting a baseline is absolutely okay. The second reason is patient avoidance. Oh, you know what? Maybe I'll try that new hearing aid that's coming out. I really hate to go through another surgery. I'm doing okay. Yeah, it's all right. Those are all the things that we hear when patients come in. So here's why it's complex. We no longer look at a patient and say, let's just look at their audiogram and a speech recognition. We look at all these different things to help us determine who a candidate is for a cochlear implant. And each of these things are equally important. Here's an audiogram. The one on the left is maybe a candidate that we would consider we might be able to preserve some of the low frequency hearing, and they would be an A+E or acoustic and electric listener. Then we have the patient on the other side with the red who's a standard electrode candidate. So this is an audiogram. Here's an audiogram of a patient who might be a CI candidate. Looks pretty simple. but it's really not that simple. But if we can streamline it and use something like this to help us educate or make audiologists that are outside of the cochlear implant field more aware of an audiogram, maybe they'll be more ready to refer to us. We also do speech recognition scores using the minimum speech test battery. We all know it here. It's not a surprise. We do AzBio sentences in quiet. We do AzBio sentences in noise, CNC words, and we test them over time. Hearing aid clinics, they don't use these tests. I don't even know if they're readily available to them. I know you can get them from Cochlear, Advanced Bionics, all the cochlear implant companies, but do they know that? That isn't what they use to determine if a patient would benefit from a hearing aid. So if we throw them a score and say, hey, how about that AzBio sentence score of this? Refer them on to us. They don't do that. So how do we make it more streamlined for them? What about a tiered approach? Tiered meaning you have a foundation and each tier is equally as important. Here's the outside referral. If we present one number, and I'm talking to you now as the hearing aid audiologist, hey, refer your patient if they have a PTA at 5, 1, and 2, that's 70 dBHL. Going back to that earlier audiogram, that would fit nicely in there. The low frequencies would hopefully be referred, but then the upper frequencies, 1,000 and 2,000, may be more of a profound hearing loss. But what about a speech recognition score? So when I talked to these audiologists and told them, hey, we'd like to use a 70 dB PTA, they all said, well, what about speech? I think audiogram is nice, but I want to know a speech recognition score when I can send them on. How about 60% or poor? The problem with coming up with a number, and I talked to them about this, is that in itself is complex. There is a lot of variability in how we do a speech recognition score. There's test material. Do you use an NU6 word? Do you use W22 words? Do you give 10 words? Do you give 25 words? Do you go 30 above their SRT? Do you go 40 above their SRT? There's a lot of variability just in that. But if we had to put a number on it and say, let's pick, I'd say 60% are poor, and then they come in, maybe they're not a candidate, but we now have a baseline. Tier 2, now they're at the audiologist clinic. CNC word scores. CNC word scores have been used in our clinics for a long time, and I think we have a pretty good internal understanding of what a CNC word score might be for a patient post-operatively. What I like about CNC word scores for candidacy is it's a word score. There's no context. There are no memory issues that have to be invoked to remember a sentence. There's no background noise, which makes the signal even more complex. So the CNC word score really gives us an avenue to understand what that patient is hearing, how they understand. But we can't leave AzBio sentences out because we don't talk in one words, in single words. We talk in sentences. So that also needs to be considered. But when we use sentences, we often put them in background noise. That's pretty realistic. That's how we listen. We are also required to have a connected speech score for insurance purposes. So that's also important in evaluating our patients. What about validation? I think it's important. Validation initiates counseling. Validation initiates accountability. So if I say to this patient, what are your goals for getting a cochlear implant? And then I follow that up after they have the implant and ask them, are we meeting your goals? If they say no, that's a perfect chance for us to help them use some of the tools that came in their box. That's a perfect chance for us to make them accountable at the next appointment when we ask them, are we meeting your goals now? Is the cochlear implant meeting your goals? Yes, I am using my mini mic. And there's a couple different tools that we could use. We could use the SSQ, which is the speech spatial quality. This gives you a situation in each of those 3 domains, and then it asks the patient to rate. I have difficulty from a 1 to 10, extreme difficulty to no difficulty. We can follow that over time. It gives us something to hang our coat on for each of those 3 different domains and work with the patient if they're having issues in one of those areas. But the cozy is also nice because that asks the patient their goal. And then that we can follow up, see if that goal changes, and makes them accountable because that's what they said they wanted to achieve. And finally, medical clearance. That would be the last tier of this, where they go see the surgeon, they have imaging and other types of appointments before they have their surgery, like anesthesia. So, candidacy is complex. We think about a lot of things when we're determining if a patient is a candidate for a cochlear implant. I absolutely don't expect a hearing aid audiologist to be able to do that off the cuff of their sleeve when they don't do it every day like we do. And so if we can allow for a more straightforward process for indicating when to refer, I think that'll be helpful. But streamlining that process will also be helpful to our clinic because we'll all be using the same type of thing to determine if a candidate, if a person really is a candidate for a cochlear implant.